Welcome to our weekly show for the National Association of Independent Medical Practices. You can find us at NAIMP.org. NAIMP is an organization focused on helping independent medical practices become more successful by providing innovative discussions, networking with like-minded professionals, and opportunities for growth, education, and increased revenue. Check out our website today at naimp.org.
Hello, this is Shirley Crest-Dudley, and welcome to our NAIMP show today. Our topic today is independent or employed, why fight for freedom? All across the country, hospitals are buying up independent medical practices at a brisk pace. While the temptation for independent practitioners to become employed is understandable, the trend toward consolidation is driving up health care costs and lowering quality of care and access. The talk today will explore the dynamics of driving this trend, the consequences to practitioners as well as patients, and alternatives. And our speaker today is Marni Jameson. Marni is the Executive Director of the Association of Independent Doctors, a national nonprofit designed to support the interests of independent physicians. Prior to assuming that role, Ms. Jameson was a senior health reporter for the Tribune Media, writing for the Los Angeles Times and the Orlando Sentinel. She is also past president and founder of a medical marketing firm, the author of 2 books, a nationally syndicated columnist, and a frequent TV guest and speaker. So Marni, we're really excited to have you today, and this topic is so relevant for our listeners, independent or employed. If you can tell us a little bit more about you and how you got here, and then walk us through why should we fight for our freedom to stay independent.
Well, it's my pleasure to be here, Shirley, and I'm so eager to speak to people in this field who care about the future of medicine, because this topic is a very misunderstood and miscommunicated topic that has huge ripple effects across the country. Just a simple question of whether or not a physician is employed by a health system or independent can cost consumers thousands and thousands of dollars that they don't even know about. And the way the system is working, physicians' reimbursements are becoming lower and lower, which is forcing them into employment. So it's a very, very concerning dynamic that we're working hard to reverse. So with all that, and thank you for your excellent introduction, with all that, I'll tell you a little bit about how I got into this role and what we're doing today and why practitioners need to be on board. So I started out of journalism school in a hospital, and I worked in a Northridge Hospital Medical Center in Los Angeles in their public relations department doing their PR. And while I was doing that, it was back in the days when managed care was taking a big hit on the physicians' incomes, and some of the medical staff were coming to me asking if I could help them promote their practice. So I started doing a little bit of that on the side, newsletters and direct mails and press releases for the independent practitioners. And the hospital I worked for told me that was a conflict of interest. Well, I was 22 years old and didn't even know what that meant. So I figured out that really meant I couldn't work for the doctors and work for the hospital. So I did some very simple math, which was about the extent of my math ability, and I realized that I could make more money working for the physicians than I could working for the hospital. And by the way, I thought this was short-sighted on the hospital's part, because here I was trying to make the doctors more successful, which ultimately would benefit the hospital. But what did I know? So I left, and in 3 months I needed a secretary, and pretty soon I had a full-fledged public relations and marketing firm on Ventura Boulevard in the heart of LA, representing many of the major medical centers and medical groups in the Southland. So that was quite a ride and taught me a lot about healthcare and the dynamics and the various forces that physicians must navigate and face as the market dynamics change. Well, about 10 years after I'd done that for a while, I was having my second child and decided I needed to downshift, and it was getting kind of overwhelming, and I really always wanted to be a journalist, which is why I went to school. So I sold the practice, the medical marketing firm, and I became, inadvertently, the LA Times asked me if I would start writing for them because I had such a handle on the medical landscape in the Southland. So I thought, well, sure, I'll freelance a little bit for the LA Times. That would be a good thing to do while I'm home with my kids. Well, that grew into a pretty huge reporting topic and job, and I continued working from home, and then eventually they teleported me over to the Orlando Sentinel. About 4 years ago, I started being their senior health reporter because there was a whole lot going on here. So that's kind of a little bit about my background in health and health reporting and health marketing. So as I started writing for the Orlando Sentinel, Orlando doesn't sound like it's got a lot going on, but believe it or not, it's really an unusual marketplace and kind of the pinnacle of this problem that physicians are facing across the country. Orlando, though it's only the 26th largest metro in the nation, has the number 2 and the number 6 largest health systems in the country, the nonprofit health systems. Florida Hospital is number 2 in terms of gross profits at $11 billion, and Orlando Health is number 6 at about $7 billion a year, and these are nonprofit institutions. Well, they're in fierce competition with one another in our little small market, and they are buying up physician groups right and left. So I was covering this for the Orlando Sentinel, trying to get my head around all the dynamics that were impacting consumers. And as a reporter, my job is to report from 360 degrees. So I would talk to the insurance companies, I would talk to the hospital, I would talk to the physicians, I would talk to the both the employed and the independent physicians, talk to patients, and one of the folks I kept coming into contact with was a fellow named Tommy Thomas. He's a CPA in Orlando, actually the little town of Winter Park, and he and his partner, Carol Zurcher, represent 115 independent physician groups. They're the accounting firm for these physician groups. Those 115 physician groups represent about 40% of their total practice. So 60% of their practice is other business, but a good portion are medical practices. And they were seeing firsthand the impact on physicians and the community that was occurring when hospitals were acquiring these independent groups. And they will be the first to tell you this wasn't about saving their livelihood. They've been in business since the 80s. They're fixed for life. They would have to lay off maybe 10 of their 30 employees if they lost all their physician groups to the hospital, but they would be fine. What they were really doing was trying to support and speak out for independent physicians, but it was kind of the deafening backlash from the hospitals was silencing much of what they had to say. So I would interview Tommy Thomas occasionally when a hospital was buying up a physician group, and I found that as I looked at this angle from all sides, the story from all sides, I really felt as a reporter that Tommy Thomas was on the right side of this thing, that buying up independent physician practices was bad for doctors, bad for patients, bad for consumers, bad for the community. But I couldn't say that. As a reporter, what you think and what you know and what you report are 3 different things. But I certainly was getting an education and having my eyes opened. So I reported on this topic, and eventually Tommy Thomas called me and said that he and Carol Zurcher were doing something pretty innovative. They were going to launch the very first National Association for Independent Doctors. There were little pocket organizations around the country that hadn't gotten much traction, but they intended for something much, much larger. And they asked me if I would come and cover the event as a reporter. So, of course, I did. I wrote about this nationwide trend of hospitals acquiring physician groups and about the fact that this group was forming in Orlando, in Winter Park to be exact. 120 physicians showed up that night to listen to what Tommy had to say, all independent doctors, and 100% of them by the end of a couple of weeks had pledged $1,000 to join the association and give it the seed money that it needed to take off. Fast forward, that was in April of 2013. Fast forward to last summer, which would be July of 2014. Tommy Thomas and Carol called me and asked if I would join them for dinner. I, of course, thought they wanted more media, which is why most people asked me to dinner. But it turned out they didn't. They wanted me to run their organization. They felt that they needed someone who could devote full-time the efforts and energy to take this to the next level. They had already acquired almost 300 independent physician members and were in 8 states. They'd spoken on Capitol Hill. They presented on a national level. And they were running a full-time CPA firm, and they didn't have any more time to devote to this. And they felt that I would be a good communicator for the organization and that I understood the issues and brought with me some credibility, which I hope is true. So here I am. And that's a long-winded way of saying I have a lot of interesting background to bring to this. And I'm not a business person. I'm a journalist and a communicator. But I think that I'm in the right place at the right time. So with that, I wanted to talk about the fact, something that most of you already know, that our healthcare system in America has some serious problems. While our nation delivers great, great care, it is at a price that is higher than any other developing country. It's 19% of our gross national product. I believe if you add up the next 10 developing countries, it doesn't match 19% of what we spend in gross profit. So it's an enormous amount, and we are getting better outcomes. And there are a lot of reasons for that. So one of the reasons is this issue of hospitals going to work for physician groups. Now, I'm going to go into the 7 consequences of that in just a minute, but first of all, it is a big trend. According to Accenture, the percentage of physicians who are independent has dropped from 57% in 2000 to about 1 in 3, or 36%, as of 2013. And every day more and more physicians are giving up their independent practices to become hospital employees. Well, okay, so what's the big deal? Well, first of all, we all understand, I'm sure all of you listening understand why doctors are doing this. They're nervous. The system isn't working for them as well as it used to, and they are getting squeezed on their reimbursement rates. They don't get equal pay for the employed physician counterparts doing the same exact procedure. They're concerned about electronic medical records. Doctors are, between the Obamacare and the different regulations coming down from Medicare, they're feeling like they need to invest in electronic medical records that may be beyond their ability to pay for. They are losing referrals to other employed physicians. We'll talk about that in a little bit. I think one of the biggest reasons is they really, and I don't blame them. I don't blame them one bit. They are sick of spending too much time running the business of medicine and not practicing medicine. So many are lured into employment because they, quote, just want to practice medicine. And a hospital will come in and say, we'll take over your overhead, we'll take care of your marketing, we'll cover your malpractice insurance. All you have to do is practice medicine. Well, that sounds too good to be true. It kind of is. So but it's still tempting. The reason we know that it's not such a great gravy train is, as I heard one doctor tell me, who was an employed physician, by the way, I know of no happy doctor who's employed. So in another way of saying that, the only happy doctors I know are independent. It becomes some kind of golden handcuffs for these physicians who go into employment, and sometimes the handcuffs aren't even golden. So, but you understand why physicians are doing this. I get it. Hospitals, of course, are doing this because they want to capture market share. So in Orlando, one of the things that happened here was a group called Physicians Associates was acquired, a group of 95, mostly primary care physicians. It was a very contentious purchase, and the 2 major hospital systems, Florida Hospital and Orlando Health, were vying mightily for this crown jewel. And the doctors were resistant because they knew they were going the dark side, but they were also, ultimately, Orlando Health prevailed, paid $50 million for the practice. Each physician got $500,000. That's pretty hard money for them to turn down when the average family practitioner or even internal medicine doctor practicing primary care makes about between $80,000 and $120,000 a year. So I get it. The hospitals are buying doctors, and when they buy these primary care physicians, they then require them to channel their referrals to employed physicians, not to independent doctors. Then they also ask them to only use the diagnostic services that the hospital owns. So funnel the mammography tests or the EKGs or the MRIs to hospital-owned facilities. and that boosts the revenue to the hospital. And we'll see in a minute that if you were to refer to independent physicians or refer to freestanding medical clinics and diagnostic services, the cost would be far, far lower to the consumer and ultimately to the American taxpayer. Nonetheless, hospitals are capturing market share, channeling referrals. They also expect their physicians to meet certain quotas. So they track their referral patterns. So when they expect these doctors to make a certain number of admissions and order a certain number of tests and make a certain number of referrals as part of their contract, or their contract might not get renewed. So that's another way they have of controlling the physician's behavior, so the behavior is more in line with the hospital's revenue stream. So we've touched on that. Obviously isn't good for patients, but let's talk a little bit more about why this is so bad, why this trend is so bad, and why we need to work hard to reverse it. First of all, one of the big problems with this consolidation that's happening across America is reduced competition. Anytime a hospital is buying up a physicians group, that's one less physician group that's in the competing market, and the rest of the independent doctors don't have as much leverage in the community. And we all know monopolies are not good for prices or quality, and that's what's happening. I'm going to take a moment to tell you about a case that just came in that we were involved with that shows why we're not the only ones who think this. In Idaho, there was a hospital, St. Luke's Health System, a couple years ago purchased a medical group called Salter Medical Group, a 35-physician, mostly primary care, but also some multi-specialty physician group. It happens to be the largest medical group in the state of Idaho. Down the street, St. Alphonsus Medical Center said, that's not fair. That violates antitrust laws, and you've just formed a monopoly. Well, the Federal Trade Commission agreed with St. Alphonsus Medical Center, and they got together and sued St. Luke's Health System for violating antitrust laws. The District Court of Idaho agreed with them and said, this is a violation of antitrust laws. You need to unwind this merger. Well, St. Luke's didn't like that because they wanted to hang on to these physicians who were going to, of course, St. Luke's will say this integrates care, it makes a more seamless experience for the patient, it consolidates electronic medical records, it's all good, and this is what we need to do. Except that there's no evidence that that's what happens. That's just what the hospitals say happens. So St. Luke's wanted to hang on to their treasure that they had paid a lot of money for, I believe $30 million, it said in court records. And they appealed the case to the Ninth Circuit Court of Appeals, the U.S. District Circuit Court of Appeals for the Ninth District. And then we then got contacted, we being the Association of Independent Doctors, because we are the only association speaking out on behalf of physicians on the national level. They asked us, those parties to this case, if we would weigh in with an amicus brief, which is a friend of the court opinion. So we used our resources to hire a top hotshot Washington, D.C. attorney to write, a friend of the court opinion, an amicus brief saying that the high court, the Ninth Circuit Court of Appeals, needed to support the lower court's decision and uphold that decision and require that this merger be unwound because the competition was creating higher prices in this market and lower quality of care. Well, we sat and waited, and I'm happy to say that on February 10th, just a week ago, we got the verdict in from the Ninth Circuit, and they upheld the lower court's decision across the board. So unless St. Luke's can pull a rabbit out of a hat and take this to the Supreme Court, they're going to need to unwind this merger, which will be very good for America. Now, what's important about this case is that the nation was watching it, and we hope that it puts hospitals on notice that they can't just willy-nilly go buy these big groups and not expect there to be some market repercussion and legal repercussion. So that's just an example of what's going on a macro level and what we fight for and what I think you all will agree needs to be fought for. So less competition is something that happens when hospitals acquire physician groups. Oops, hang on. Now, quality goes down, and people wonder why that is. Well, it goes down for a couple of reasons. When hospitals acquire physician groups, those physicians are required now to refer only to other employed physicians, and the hospital, again, tracks the referral pattern. What if the very best breast surgeon is an independent doctor? What if the very best gastroenterologist is an independent doctor? Some of the very best doctors are independent. They don't have to succumb to employment. However, these doctors aren't getting the referrals anymore because the doctors making the referrals, the primary care physicians who are now employed, must refer only internally. So that's one way quality of care goes down for the patients. They lose access to the best providers. Another way that quality of care goes down, and this is to me the fundamentally most disturbing part of this whole dynamic, is that when a hospital acquires a physician, the doctor's allegiance to the patient must shift from the patient to the employer, whether they like it or not. That bond between the physician and the patient is forever damaged because now the doctor must march to the drumbeat of the hospital and order the required tests and procedures and do the requisite admissions to meet his quota in order for his contract to be renewed. So patients get put in harm's way. They get unnecessary tests and procedures done. Every single year in America, 440,000 people die from hospital errors. Now, to put that in perspective, that is like a city the size of Miami to be blown up and everyone in it killed every year from hospital errors. Now, I'm not saying that all these hospital errors are done because of independent or employed physicians making admissions, but the chances of your getting an error or being wrongly admitted and being in harm's way go up exponentially if you get a procedure that you weren't supposed to get in the first place. So that's extremely concerning. The America's Health Insurance Plans is an organization that represents and speaks out on behalf of insurance providers across the country, and they have seen that the harm increases substantially when hospitals employ physician groups. They are also, although they have to be nice to the hospitals because they are a big source of revenue for them, they also recognize that independent physicians are better at providing care for a lower price. We talked about access, we talked about choice. I think another part of the problem that's very concerning to me is patients don't recognize when their doctor gets acquired by a hospital how much that will impact them almost until too late. Sometimes they never do. But if I go to get an EKG one day from an independent physician and the next day that independent physician becomes acquired by a medical group and I don't know it, and maybe this is a cardiologist, well, all of a sudden that cardiologist is referring me into his system, and I don't know that I'm not going out to the independent freestanding centers anymore. I'm only going to the hospital-owned echocardiography center or the hospital-owned EKG lab, and all of this is we're going to talk about this in a minute, all of this is going to increase my costs, but I don't even know that I'm getting funneled into this system and that options are closed for me. So less choice is a big problem when hospitals acquire physician groups. Now the big one is higher costs. Now this is scary, but I'll give you some examples here. The Medicare created an advisory panel, the Medicare Payment Advisory Commission, to look at the various costs of Medicare and try to figure out why they were so high and what they could do to bring them in line. And one of the things that we're calling this MedPAC, the Medicare Payment Advisory Commission, found was that the Medicare pays substantially more for a hospital-owned facility than they do for an independent freestanding center. Here are just some examples. It's usually about 4 times more expensive to get any procedure done, an MRI, a heart cath, an EKG, colonoscopy, you name it. It's usually 1/4 to 1/5 the price for patients to go to an independent facility or an independent physician versus a hospital-owned physician. So what they recommended was, and this should be self-evident, but they recommended a site-neutral policy, that Medicare pay the same amount of reimbursement for the same procedure regardless of the setting and who owns the setting. Well, you would think that would be something that would be easy to do, but they didn't like that. The hospitals don't really like that idea. We'll get to that in a minute. But another study just along the line of why does increased cost if hospitals buy up doctors and patients go to those employed physicians. This is the mean cost per inpatient, a study that came out in the Journal of the American Medical Association last fall, showed that, now this was a big study, by the way. This looked at 5 million patients in California over a few year period. It wasn't a small study. And they analyzed the cost for each one of these patients, and what their mean inpatient cost was. I believe this was per day. And this is how it breaks down. It's on a rate, it's $3,000 for an independent doctor. If you're a patient of an independent doctor, that's what your daily rate will be based on the procedures and tests that this physician orders. But if you go to a doctor that's owned by a large multi-hospital system, it goes up 50% to $4,776. So that's another eye-opening statistic. So what MedPAC found was that if hospital facilities charge the same as independent doctors for the same services for 66 groups of services, these are the core services, not even all of them, the taxpayers would save $900 million a year in Medicare costs. Now there is a proposal right now going forward with Medicare for them to adopt this, but it is getting resoundingly fought by, guess who? The hospital systems. Now, independent doctors by nature are independent. They don't organize well. They don't behave well in groups. And they're autonomous by definition. They're independent, right? So guess what? How much money do you think independent doctors spend lobbying Washington? Any guesses? I'll tell you. A big fat zero. Zero money spent lobbying on Washington. Hospitals, meanwhile, the American Hospital Association spends $20 million a year on Washington lobbyists, making sure their needs are represented. They have the upper hand. Well, what they say about MedPAC is that the inclusion of a site-neutral policy is premature and ill-advised. They say that, they say that it would be a big mistake for hospitals to go along that route. And they feel that they should get more money because they're open 24/7 and they have to that's part of the cost of doing business. Well, I think that we can all recognize that there may be charged a little bit higher, and they don't need to charge quite as much. All right, higher costs for a lot. Another thing that happens is you've probably heard about facility fees. Facility fees are a fee that get layered in when a hospital owns a physician group or a facility that does not get factored in when independent doctors or freestanding facilities are involved. And it amounts to several $1,000s for some kinds of procedures. This facility fee adds absolutely zero value, zero quality. It's completely added because the hospital feels that they need to get this extra money for the fact that they need to keep their lights on day and night. Well, that is a law that we're fighting for, and other people are fighting to change. Connecticut was the first state to enact a law, and they did this last year. I believe it was the governor who saw that these facility fees were egregious, and I think he personally was affected by them, and as he looked into it, he said, this is crazy, and they have passed a law in Connecticut that facility fees need to be made transparent to the patient in no uncertain terms. They need to be posted in all of these facilities' lobbies. They need to be handed to them in a document showing this is what your charges are, this is for your care, and this is this extra facility fee that we layer in for no good reason, and here's what you're going to pay. So they know going in, before they get the sticker shock at the end, that these facility fees are involved. Kansas is on the verge of passing this law. We're fighting with our own lobbyists here and legislators in Florida to get the law passed, to get another facility fee law passed, an awareness fee, and we think it should be law in every state. Going one better, Connecticut is now considering, there's a proposal on the table to just eliminate these facility fees altogether, which would be a huge hallelujah for this country and bring costs down. Now, this is where the whole notion of consolidation and mergers and acquisition really hits home. While I Well, I go around and speak to physician groups. Sometimes I'm speaking with practice managers who, as you probably know, really are the ones who keep the train on the tracks and the wheels on the cart. They're the ones that really need to be supported here. And they're an important, these people who have jobs supporting and running medical practices are doing not only important work and in some cases some good patient advocacy. When hospitals buy up physician groups, these people lose their jobs. Now, independent practices are small businesses, and small business creates about 60% of our nation's new jobs. When an independent practice goes from being a small business to being employed, they take that support and that work they do in the community gets removed. Those institutions, the nonprofit institutions, take over the staffing, and the loss of these jobs, these practice managers' jobs and the billing specialist jobs, has a reverberation throughout the community. There's a ripple effect. These people aren't going out to dinner anymore. They're not supporting the local theater. They're not going to the dry cleaners. They're not doing all the things that having a job allows you to do, and they're displaced, and that's a shame. So we'd like to keep people employed. We are a big fan of small business. We're a big fan of small business creating stimulus in the community and providing jobs and paying taxes, which is my next point. Shocking as it may seem, when a hospital acquires a physician's medical practice, those medical practices, if it's a nonprofit hospital, they stop paying taxes. All that money comes off of the tax rolls. Nonprofit hospitals pay no personal property tax, no real estate tax, no sales tax, and no state or federal income tax. Well, as consumers, we may not realize how significant that is, but as they buy up these medical groups, there were just 2 medical groups, and we know because the CPAs who founded the Association of Independent Doctors knew what 2 medical groups were paying in property taxes since they were the CPAs. There was a large heart group, a cardiology group, and a large Winter Park urology group. They were both acquired by Florida Hospital, and when we looked at the tax records, we saw that $450,000 came off the tax rolls in property taxes alone. And who pays for that? Well, we do. In Orlando, just last year, this came out, that Orlando had to raise property taxes 17.7%. Well, nobody's saying because our mayors are heavily subsidized by the hospital, nobody's saying that's partly because the hospitals are taking all these taxes out of the system by buying up hospitals and medical groups and turning them into nonprofit enterprises. So it's a lot of money. Communities lose when hospitals buy up doctors' practices. All right, so we've got 6. I promised you 7. Final one that physicians really need to worry about is they really don't enjoy their jobs as much. As one doctor put it, nobody went to medical school to order more tests than was necessary. Another doctor I spoke to said, I do not want some administrator telling me what kind of medical device I can use or what kind of gloves I need to wear. I want to make my own decisions. Doctors are miserable when they go to work for hospitals, and they find out fast that the best year of employment is the first one. There's a honeymoon period when the hospital promises them all kinds of things, and then the contracts worsen or they get canceled. And these physicians, because they have to sign non-compete clauses, can't just walk away and say, never mind, I'm sorry, I'm just going to go back into practice, because they're not allowed to go back into practice as they were without sitting out their non-compete. And their contracts will depend on the numbers. We have a member in our association, a wonderful internist, and she worked for the hospital. And she was very happy with her physician, with her practice, and she saw about 17 patients a day. She's a primary care provider, providing internal medicine, and really liked to talk to each one of her patients at length. Well, the hospital said she needed to step it up. She needed to see 25 patients a day. We had lunch, and she was telling me the story, and she said, you know, I did for a while, but I couldn't give the quality of care I wanted to, so I just went back to the way I was doing it because my outcomes were really great, my patients were really happy, I felt like I was doing a super job, and I figured the hospital would get over it. Well, guess what? They didn't. They didn't renew her contract. So she ended up sitting out a year. She left, and she sat out a year waiting for this all to transpire and her non-compete clause to run out, and now she practices concierge medicine as an independent doctor, and she sees patients on her terms, and she's never been happier. But some doctors have to go through that cycle of working for a hospital and then getting out to realize what it should feel like to practice medicine. So those are our 7 reasons of what we all think you should know about what happens when these consolidations happen. We're trying to do this at the Association of Independent Doctors. We're trying to reverse this trend by getting the word out. We're trying to increase parity and transparency. We're trying to get physicians paid what independent physicians paid, what employed physicians are getting paid, and we're trying to make that transparent to the patients. We're working with media to try to educate consumers about the impact this has on them, and we want to do whatever we can to help physicians stay independent. And we're doing that by working with the media, which is my expertise and background, working with lawmakers, working with our judicial system, as we did with the amicus brief case in Idaho, working with insurers. We have lots of conversations with insurance companies who are kind of between the devil and the deep blue sea because they need to stay with the hospitals who have a lot of patient lives, and they can contract higher reimbursement because they can leverage those lives. But they also know that keeping doctors independent keeps costs down and quality up. So they're in a dicey position, and we're trying to help them figure that out. And that's my story. So I hope this was helpful to you in learning about, and I'm sorry it was such a downer, but it is a little discouraging. But this is why we need all to get together and fight the cause, fight the good fight, keep doctors independent, keep patients aware of these hidden costs, how they can save a lot of money by going to an independent doctor, and it's not only going to save them money, but it's going to support the independent doctor and their communities by doing this, and to be sure when they go to a hospital to make sure they request an independent doctor and circumvent the referrals that happen to them. We need to get the word out, inform, and the more our patients and consumers are aware of this, that it not even consumers who say, well, I'm young, I'm never in the hospital, it's not affecting me. Well, it is, because they pay taxes, and taxes are what pay Medicare and Medicaid, and those fees are skewed too, as we've seen from the MedPAC report. So we're busy getting the word out here. We're running as fast as we can, and we appreciate all the advocacy and concern that we can muster and generate with folks who are like-minded. So thank you for your attention today. You're always free to email me with questions. I will have the email on the link here to the website, and thank you all for tuning in.
And thank you, Marni. Really eye-opening information. Good statistics, very, very helpful to our listeners. And if you want more information, go to www.aid-us.org. That's the Association of Independent Doctors. And Marni, your email is it marni@aid-us.org?
It's Marni, M-A-R-N-I, at aid-us for United States.org. That's right.
Fantastic. I think their number is 407-865-4110. Now, if you'd like to look at those statistics again, look at the screenshots, each individual slide, and maybe listen or watch the presentation again slowly, then go to our website at NAIMP.org. And when you go, you'll also see the other podcasts and other webinars and a lot of other great information for independent medical and dental practices. So we're so glad you listened to the presentation today, and we'll see you next time.
Thank you, Shirley.
Thank you.